session. And thank you very much to the organizers for giving me an opportunity to moderate this session. I am Vignesh from the Department of Medicine. And at the outset, I would also like to welcome, and it's my privilege to also welcome Professor Vijay Samuel, sir. Sir is the Senior Professor and Head of Department of Cardiology. Thank you very much, sir, for having joined. Today's presenter will be Dr. Lino. He's a postgraduate registrar in CMC Vellore, and he has chosen a case in a patient to discuss cardiovascular system clinical examination and management. Just wanted to clarify if the virtual audience are able to hear me.
Yes, sir. Yes, sir. Dr. Anita, sir. Yes, sir. It's clear, sir. You can start proceeding, sir.
Professor Vijay, sir, are you able to hear me, sir?
Yes, Vignesh, I can hear you.
Sorry, sir.
I can hear you.
Vignesh, sir, we can hear you, sir. Dr. Vignesh, sir?
Yes, I'm able to hear you, ma'am, now.
Yes, sir. We can able to hear you. Your audio is clear. You can start. You ask the PG to start the presentation, sir.
Sure. Vijay, sir, do you want to give any comments before starting, sir?
I think we'll go ahead with the presentation, yeah.
Sure, sir. Yeah, I'll hand over to Dr. Lino.
Good afternoon, everyone.
Good afternoon.
Good afternoon.
Presenting Mr. X, 58 years old gentleman from Bangladesh, supervisor in construction company by occupation, presented to us with breathlessness for 1 year, palpitations for 1 year, and bilateral lower limb swelling for 6 months. He was in his usual state of health before 1 year when he developed insidious onset, gradually progressive exertional dyspnea. While initially dyspnea was there only while walking up to flight of stairs or up to while walking 500 meters on ground, it was NIH class 2. From last 3 months, dyspnea worsened and he developed breathlessness on even walking up to 100 meters of NIH class 3. There is no history of dyspnea at rest. There is no history of worsening of dyspnea on lying down. No history of PND. No history of cough, wheeze or seasonal variation. He also complains of palpitation for last 1 year, which was insidious in onset, regular, occurs daily during exertion and reduced with rest. There is no history of post-palpitational diuresis. He also complains of bilateral lower limb swelling for 6 months, which was insidious in onset, progressive, painless, currently up to knee.
Excuse me, are we asking questions in between or at the end? What is the plan?
Sir, you may interrupt and ask any questions in between.
Okay, thank you. Please continue.
There is no history of early morning facial puffiness, decreased urine output or frothy urine, no history of abdominal distension, jaundice, melena or hematemesis, no history of syncope, there is no history of nocturnal chest pain, no history of hemoptysis, no history of difficulty in swallowing or hoarseness of voice, no history of limb weakness, slurring of speech or blurring of vision.
Yes, you mentioned about post-palpitation diuresis, isn't it?
Yes, sir.
What is the significance of that?
So, in a patient with atrial fibrillation, due to decreased coordination of atrial contraction, atria get stretches and atrial natriuretic peptide hormone releases.
Okay, that is a mechanism.
Yes.
But what is the significance of that? If a patient has that and if another patient does not have that?
The palpitation, if the patient has post-palpitational diuresis, then the palpitation can be attributed to atrial fibrillation, paroxysmal atrial fibrillations.
Any palpitation can have it. any palpitation or only atrial origin? See, at times, patient may not know what exactly he is describing. So if there is history suggestive of post-palpitation diuresis, you can be sure that it was palpitation that he is meaning, because some vague chest symptoms can sometimes be described by the patient as palpitations. Okay. It confirms that what the patient is describing is palpitation. Okay. You have a lot of negative history already. Why did you mention about jaundice, ascites, and all those?
So for lower limb swelling, pedal edema.
Okay. But this patient has associated symptom of exertional dyspnea for 1 year.
Yes.
So at the outset, do you really think of a hepatic origin?
No, sir.
What are the causes of jaundice in a cardiac case?
Sir, cardiac cirrhosis, congestive
Okay,
hepatitis,
very rare.
congestive hepatitis.
Anything else? Any drug induced? Any drugs used in cardiac diseases on a long term can produce liver damage? Okay, please check up. Move on.
Treatment history, he was evaluated in hometown and found to have a valvular heart disease, came here for further management. Medications, he was using tab metoprolol 25 mg and empagliflozin, tab aldactone, sacubitril valsartan, furosemide, and aspirin and atorvastatin. Past history, he has no comorbidities, no history of fever, joint pain in childhood, no history of taking any injection once in every 21 days.
Do you mind going a little slower, doctor? A little slower.
Yes.
Speed.
Family history, no cardiac disease in the family, no history of sudden cardiac death in family. Personal history, he consumes mixed diet, appetite is normal, sleep is normal, bowel and bladder habits are normal. Addiction, he's an alcohol consumer for last 20 years, consumes once in a month of 180 ml of alcohol. Summarizing, 58 years old male with no known comorbidities, presented with...
Are you going to talk about the past history here or later?
Sir,
in such a patient where somebody had diagnosis. Valvular heart disease. What past history should have been mentioned so fast because we are listening to you.
Any valve replacements, any surgery?
Any history?
No, sir.
I think what the doctor is asking is, this is a gentleman who's 50 years old now, who's been having issues with recent worsening. So what kind of past history or, iatrogenic things would you ask for? Whether dental extraction, dental cleaning, any procedures, so which is producing acute worsening, because, these are things you should keep in mind, and drug history is again very important. So I think we'll go ahead. What I'll do is I will immediate mentors, the faculty in medicine can ask, and then towards the end, probably if there's any specific areas which I can contribute, I will do that. But I think in terms of your symptomatology, I think you probably go ahead, and then once you summarize, we'll discuss it again.
Summarizing, 58 years old male with no comorbidities, presented with progressive breathlessness for 1 year, progress from NIHA class 2 to class 3 over last 6 months, with exceptional palpitation for 1 year and bilateral lower limb swelling for 6 months. So differentials consider where valvular heart disease, probably regurgitant lesion, ischemic heart disease.
Okay, just a couple of questions from the history. If I could ask, you had mentioned about history of hoarseness, difficulty in swallowing as a part of your negative history. Can you tell us why you had asked that history?
Water syndrome, in case of left atrial enlargement, it can compress left recurrent laryngeal nerve and can cause hoarseness of voice. And in same time, left atrial can compress the esophagus and cause dysphagia.
Okay, so you think it's more of compressive symptoms. And you had also mentioned nocturnal chest pain. Can you explain why you asked that?
Regurgitation, especially aortic regurgitation. In the night, due to decreased sympathetic activity, heart rate will go down, and that will prolong the diastole and increase the regurgitation time. In addition to that, in aortic regurgitation, LV will be dilated, and the LV thickness will be increased, and demand will be high. But due to increased regurgitant, the blood supply to the coronaries will be low, causing nocturnal chest pain.
Or you say that the diastole may be a bit prolonged
yes,
during the night time,
yes,
so the regurgitation would be high.
Yes.
It will increase the left ventricular demand,
Yes.
and it will also decrease the coronary flow because of the regurgitation, all contributing to nocturnal angina. All right. Okay. So your differentials, you said valvular heart disease, probable regurgitant. That's your first differential. Can you specify whether you are thinking of a left-sided valve pathology or a right-sided valve pathology?
More of a volume overload symptoms are dyspnea, palpitation. It started with a left-sided, more of a left-sided valve.
So you think it is predominantly a left-sided pathology. So you think you have shortlisted mitral regurgitation and aortic regurgitation.
Yes.
Okay. So
here, if I can interrupt, I think it's very preconceived. You see how common is a 55-year-old presenting with 1-year dyspnea and you directly home into valvular heart disease. No, I think there are many more common. I think your differential you said is you need to be specific. Now, what is the prototype of a cardiac lesion which produces dyspnea? Is it stenosis or is it regurgitation?
Stenosis.
So what you said is your first differential. See, I don't see any stenosis in your thinking process. So, and what is the prototype of a lesion with mitral regurgitation?
Palpitation, fatigue.
No, it is not palpitations. It is more of fatigue. All right. So, and also, so you think wide. So what is like think of a person who is a 50-year-old. See, it is different when you have never had any significant past history. What is the scope? You said ischemic heart disease. Can you specify? So you said there was no effort angina, nocturnal angina. Is it very common to present with ischemic heart disease? Or if it is ischemic heart disease, he has no other comorbids. What is your probability for him having ischemic heart disease with it? So your ischemic heart disease, you should be substantiate age-wise, yes. But he should be having a smoker, a diabetic, so none of these pictures is there. So you need to, what is more common? What is the commonest presentation of HCM? What is the commonest presentation? Because I can say I'm a more younger patient, but again, undetected. So yes, had. Among the three, what is it? Like, is it dyspnea, or is it palpitations or angina? You can get everything?
Everything, sir.
Yeah, so most common symptom is dyspnea. Now, if you're seeing incriminating valvular heart disease, what kind of valvular heart disease can present in the age 50? That is more of a thinking process. A pre-existing lesion suddenly presents with rapid progression at the age 50.
Yes, sir.
So what is the most common prototype which can present that way?
Aortic.
Aortic, can you qualify that? In terms of which aortic, normally, it is natural progression of AS is usually in octogenarians or after 60. But yes, you are right. In an aortic stenosis, what kind of valve pathology or pre-existing condition can become symptomatic this time? Normally, the aortic valve is trileaflet. So when you have underlying bicuspid, you can have nose regurgitation. What is the other common possibility?
Degenerative.
Okay, degenerative. You said aortic valve. Agreed. So more common than that. Okay, in a presenting is typical. The prototype is mitral valve prolapse. So there is a myxomatous disease, and which usually they manifest by age 50. They can have either caudal rupture or this thing, and they can become purely symptomatic. So, and then you have to involve again myopathic processes. Like you said, based on your history, if you sort of look at your history, you said only about valvular lesions, mostly left-sided valve lesions. Is there evidence of right heart involvement? Yes, there is. So in the history, you have features of biventricular involvement, right?
Yes.
As evidenced by evidence of congestion. Did you mention the JV? You're going for the examination. Okay, this is from here. So now can you revise your differentials based on what your from your history of palpitations, what you've described, what is it likely to be? You think it is pathological palpitations, or is it because of a hemodynamic situation?
Hemodynamic.
Okay, so you said with exertion, it increases. So there's a warm up. And also important for you to have asked is, how does it come down? Okay, so you stop the exercise and then slowly the heart rate comes down to normalcy. That is again suggestive of a slow increase and slow stop, right? So, so other important history is along with it, what is the history of palpitations? How did you elicit the history of palpitations?
He told fast beating of he is able to feel the.
Now, how did you ask him, regular or irregular?
So any varying intensity, like it will be same throughout the time, or it increases and decreases throughout.
No, what you generally need to do is you need to tap on the table and say. So that way you can demonstrate as regular, irregular warm up. If it's an irregular beat at a fixed, you said it was regular, so I give it to you. So, but at least when you're eliciting history, and you said that along with the history of palpitation, should have mentioned syncope or pre-syncope. You mentioned subsequently in the negative history, but palpitation history should have that. Did you ask for any neck pulsations?
Oh, yes, I didn't ask it.
Okay, so what does neck pulsations in the palpitations describe?
In supraventricular tachycardia, we can see neck pulsations.
Right and wrong, but usually when there is AV dissociation, when the atrium, contracts against a close AV valve, they are the largest thing, neck pulsation. The ATF said is right. AV inactive, when you have AV dissociation, it's not synchronous, you can have neck pulsations. And how it terminates. So initiation is important. How it terminates, here you said exertion, stopping exertion, it helps. Okay, so if it is palpitations, what is the explanation of palpitations in a mitral regurgitation versus the explanation in an aortic regurgitation? Okay, I think we'll go on to that. So we'll go on. So can you revise and see your history? I mean, based on your findings, can you tell us summarize your differential diagnosis a bit better with what the inputs you've had?
Yes, sir. Can be a valvular heart disease. Can be an aortic valve lesion. Or a mitral valve lesion, sir.
Okay, in terms of disease prototypes, you would think of a hypertrophic cardiomyopathy. Okay, and you think of a regurgitative valvular heart is predominantly involved in the vital. See, because in terms of probability, you would think of a MVP-MR. Lead to a bicuspid stenosis, but your symptomatology is slightly different. And or myopathic causes like a dilated cardiomyopathy. All right, these are common symptoms, common differentials you will keep as you move forward, and you will be looking for findings. All right.
Examination, say elderly gentleman, conscious, oriented to time, place, and person, not in respiratory distress, lying comfortably in propped up position, with a pulse rate of 90 per minute in the right radial artery, irregular in rhythm, high volume collapsing pulse, with a normal atrial wall. All peripheral pulses were equally felt and with no radial delay or radiofemoral delay. Blood pressures in the right arm in supine position is 110/50, and the left arm is 110/56, and in the systolic BP in the right leg with the palpatory method is 140, and in the left lower limb is 140. Respiratory rate is 20 per minute, thoraco-abdominal type, and he is afebrile at time of examination. JVP is normal 6 centimeter above the sternal angle at 45 degrees. There is no pallor, icterus, arcus ulnaris was noted. Fundus showed no Roth spot. Oral cavity had caries. Tongue was up normal. No clubbing, cyanosis, lymphadenopathy, and pitching pedal edema was up to mid-shin. There is peripheral signs of aortic regurgence were noted. A collapsing.
Can you tell us what is J?
Sir.
Sorry, sir, your voice was breaking, sir. You were not clearly audible.
Oh, sorry. Can you tell us what is JVP?
Undulating top of oscillating column of blood in the right internal jugular vein.
No. Are you talking about the pulse or the pressure? Are you talking about the pulse or both are P? No?
Yes, sir.
You should be talking about the waveforms first.
Yes, sir.
Then you measure the wave, right? First is the waveforms. Very important in such cases.
Sir is asking what are the waves that you identify in JVP and what specifically did you look for with your tentative historical diagnosis? What did you specifically look for? I think that's.
Sir, JVP can include A wave, X wave, X descent, C wave, V and Y descent, sir. In my patient, one because of palpitation, possibility of atrial fibrillation can be there. I look for whether A wave is there or not.
Yes.
Then
What is the finding?
Sir? Sorry.
Sorry, sir, the last part was not clearly audible again, sir.
Lino, meanwhile,
Yes.
till Dr. Krishna comes back, see, when you see the JVP was not visible 6 centimeters just above the clavicular, is that what you mentioned?
Yes, sir.
So when sternal angle So if you cannot see the waveforms in this position, what can you do?
So,
So you're not able to see the waveforms. You understand, you describe the waves to me. I mean, what are the normal you expect? But here, so here you said you're not able to see I presume you couldn't see. So in a patient in 45 degrees, what to see the waveforms, what can you do?
hepatojugular, abdominal jugular reflex we can say.
Oh my God. Jugular? Are we talking about jugular? Can you hear me, please? What is a normal jugular venous pressure? JVP value, normal. Normal jugular venous pressure.
Less than 4, sir.
Less than 4 is it 0?
Sorry, sir.
Also, than 4. That's what sir was mentioning just now, right? Is 0 normal?
I think there
You
are
do
two
hepatojugular
things. One
to
is,
measure the jugular venous pressure. You do the hepatojugular reflex to measure the jugular venous pressure.
No,
Press
sir.
and measure.
No, sir.
What is the normal lower limit? You said below 4, I agree. But then is 0 normal? Please go on.
I think we need to clarify for the benefit of others. So if you can't see the waveforms in 45, what you could essentially do is probably tilt the head down or bring the pillow down. And you can see the waveforms then. So then you can comment on the waveforms. But I presume the patient is on diuretics or probably euvoluming. The other thing is because this is important here, it is not, so the waveform tells you one thing and then the pressures. So you need, what you measure is in centimeters of water. You need to know how to convert it into millimeters of mercury. But so that is one conversion you should know. And then the RF pressure is taken as above, mid phlebistostatic axis, that the mid right atrium is taken as 0. So when you add on, you need to see 5 plus 4 or whatever, that is what they add, and then you convert it into millimeters of mercury. So that is one thing. So when in your patient, you had basically pedal edema history, and then it is important, if you're not evident, to do the hepatojugular reflex to see if there's features of congestion. So that is what. So I'm not going into, because we have quite a bit to discuss, I'm not going to do how we'll do a hepatojugular or posterior reflex. So we'll go ahead. Yeah.
In which condition you get non-pulsatile jugular venous? Non-pulsatile jugular venous pulse. Non-pulsatile. I'm not audible, I think. Anyway, please continue. I think there's a connection problem with this side or that side. I don't know. Please continue.
No pallor, no icterus, arcus celinus was noted, fundus no rot spot, oral cavity caries noted, tongue appear normal, no clubbing cyanosis, no lymphadenopathy, pitching pedal edema was up to mid-shin noted. Peripheral signs of ER noted, sir. Collapsing pulse and drop sign and hill sign was noted, sir. There is no peripheral signs of infective endocarditis is noted. Central cardiovascular system examination, inspection, tracheosis in midline, no precordial bulge is noted, sir. Apical impulse is visible lateral to mid-clavicular line below the level of nipple. No scar, sinuses or dilated veins are noted, sir. Palpation, apex beat is present in 6th intercostal space, 1 centimeter lateral to the mid-clavicular line. It was hyperdynamic in nature. Grade 2 parasternal heave, which noted
Blood
with...
pressure, please. I just missed it. Blood pressure.
In the right arm, it's 110/50, left arm 110/56. Lower limb by right leg systolic BP is 140, and then left leg it is 140, sir. Palpation, apex beat is present in 60 intercostal space, 1 centimeter lateral to mid-clavicular line, and
No,
hyperdynamic.
can I just interrupt you here? Can you just go back to your pulse page? I mean, the slide. Yeah. So, so yeah, high volume collapsing pulse. Okay. So where did you examine for the collapsing pulse?
So, in the radial artery first, in the hand first, we will check the radial pulsar, and slowly we'll go towards the behind at the point where there is when you feel less the pulse, we'll encircle the forearm, and with the other hand we will encircle the wrist, and we will raise the hand so that the arm and it will be in middle straight line with the right atrium, sir.
Okay, so what are the ways does it get augmented? You said one is a straight line, that is one thing. Then
Diastolic run.
So pulse is a systolic feature or is a diastolic feature? So peripheral vascular resistance and that comes down, so the runoff is augmented. And then the most important thing is gravity. So you're doing it against gravity, so that augments it. So it's important to have that. And where did you see for the character of the pulse?
In the carotid, sir.
Okay, good.
Raise the hand. When you raise the hand above the level of the heart, normally what happens to the radial pulse?
Not sure.
I'm not sure. When you and me normal people, when we raise the hand above the level of the heart, what happens to the radial pulse? And what happens in collapsing pulse? The sufficient to push blood even up to the roof of the operation theater. You've seen that, no? When a major artery is cut, the blood hits the roof. So nothing happens to the radial pulse when we raise the hand above the level of the heart. But in collapsing pulse, there is a peripheral rundown. There is a peripheral rundown of the radial pulse. Please continue.
Palpation, apex beat is present in 6th intercostal space, 1 centimeter lateral to mid-clavicular line, and hyperdynamic in nature. Grade 2 parasternal heave, which is synchronous with apex, and palpable P2 is noted, sir. Systolic thrill was present at apex. Percussion, normal right heart border dullness corresponds to sternum, and left corresponds to apex beat. Dullness is noted in the left second intercostal space. Auscultation in mitral area, S1 is soft. There is a grade 4 high-pitched soft blowing pansystolic murmur at the apex, which is radiating to axilla. Best heard with diaphragm of stethoscope in left lateral decubitus position with breath held in expiration. In tricuspid area, there's a grade 3 high-pitched soft blowing pansystolic murmur at left lower sternal border, best heard with diaphragm, patient in supine position and breath held in inspiration. In pulmonary area, P2 is loud and no murmurs heard. In aortic and neo-aortic area, there's a grade 3 high-pitched soft blowing decrescendo diastolic murmur in right, second and third intercostal space, best heard with diaphragm of stethoscope in sitting up and leaning forward position with breath held in expirations. Respiratory system examinations, tracheus, central, normal vesicular breaths are here, no other sounds noted. Abdomen is soft, non-tender, no organomegaly, no free fluid noted, sir. CNS, no focal neurological deficits noted.
Sir, Vijay Samuel, sir. Sir, any questions till the end of examination, sir?
Can you just go back to the cardiovascular system examination? Yeah. So you said apical impulse is visible, lateral midclavicular line. So it is able to see below the level of the nipple is a very subjective term because it depends really on the habitus. So it's better to say in the rib count. So you start from the sternal angle and clip. So because the level of nipple can be very variable. So you need to mention that. So only then can you determine. So what you're trying to see is the left ventricular enlargement or not. Now, go on to the next slide. So, can you describe what a grade 2 parasternal heave is? And no, before that, what do you mean by a hyperdynamic nature of the apex?
Increase in amplitude with it occupies more than one intercostal space, and it's more it is more than one third, but less than 2/3. It occupies almost more than 1/3, less than 2/3 of systoles.
You heard of murmur, systolic murmur in mitral area and tricuspid area, right?
Yes, sir.
Which is the origin? Is it from the tricuspid area or mitral area? Or there are two murmurs?
There are two murmurs, sir.
Okay. Why do you say that?
So the murmur which I heard in tricuspid area increased with inspiration, whereas the murmur which I heard in mitral area did not increase with inspiration. Instead, it is better heard when breath was held in.
Murmurs? Pardon me?
Sorry, sir.
Grade of the murmurs.
So, different, sir. There was a thrill in the yes.
Okay. Did you examine the abdomen?
Yes, sir.
For what?
So hepatomegaly.
Hepatomegaly. Why?
So pulsatile hepatomegaly is seen in with severe tricuspid regurgitation. Also
Okay.
in aortic regurgitation also you can see pulsatile hepatomegaly. And if RV is enlarged, you can see epigastric pulsation. You can feel epigastric pulsation.
Good. Epigastric pulsation. Yes. Anything else in the abdomen?
The free fluid.
Yeah. Okay. Did you auscultate over the abdominal aorta? No. Did you auscultate over the back of this patient? Posterior part of the chest?
Yes, sir. When respiratory system examination, I auscultate post.
No, not respiratory system. Particularly in view of your findings in the CVS in the heart.
No, sir.
You can get the MR murmur going
Yes, sir.
very widespread in the back.
Yes.
There are case reports where they said MR murmur can radiate from vertex to coccyx. From vertex to coccyx. So is it heard, MR murmur at the back?
Above the axilla, I was able to hear even above the axilla, sir. Beyond the axilla.
Okay. Depending on where the murmur is conducted, what is your thinking about the mitral regurgitation?
Mitral leaflet, if it is posteriorly radiating, anterior mitral leaflet is involved, and if it is
So do you include heart failure in your diagnosis right now? Is this patient having heart failure?
He has heart failure, sir, but he
Hmm.
has biventricular failure.
He has biventricular failure. Why? Please explain.
Dyspnea,
Hmm.
pedal edema.
Hmm.
Because it's on diuretics, there is no JVP elevation. Chest is also
Mhm.
clear.
How do you know he's on diuretics?
From the treatment history I got he was already on diuretics.
From the treatment history. Okay. And you can easily ask the patient about urine output, right?
Yes.
Even if you don't know the medical history, you can ask him how much urine he is passing, or even a good patient will tell you about the body weight changes. Every day you will be measuring the body weight, right?
Yes, sir.
People on diuretics. So that's easy in the history. Okay.
Okay, so just before you come into the diagnosis, just a few comments or suggestions. I mean, in the history, at the end of the history, even Vijay Samuel sir had suggested some differential diagnosis that you should be considering. Now, with all those inputs, do you think you have any other general examination findings that you think you should have added on? Especially in light that when you suspect mitral regurgitation in these age groups.
Arms, height, weight, and arm span.
Yes, so you should, it would have been good if you had also mentioned about marfanoid habitus, including arm span, height, upper segment, lower segment, and specific. What other general examination findings of marfanoid habitus that you would look for?
Rectus excavatum. So,
What is there in the eye?
ectopia lentis.
Posterior subluxation. How do you recognize posterior subluxation? I mean, ophthalmologists do slit lamp examination, but clinically, how a physician can make out posterior subluxation if present?
Not sure, sir.
You look for iridodonosis. Iridodonosis. Okay, please continue.
Okay, so your provisional diagnosis was probably an aortic valve disease, maybe an aortic regurgitation at the end of your history. Can you list out some causes for aortic regurgitation?
When it is secondary to aortic valve disease like rheumatic heart disease, post infective endocarditis, if it is secondary to aortic root dilatation, aortitis, condition causing aortitis, arteritis like syphilis, Takaysu-arteritis, giant cell arteritis, connective tissue disorders like Ehlers-Danlos syndrome, Marfan syndrome, autoimmune disorders like SLE, rheumatoid arthritis, ankylosing spondylitis, even hypertension with aortic root dilatation can also cause aortic regurgitation.
Okay, so now that you have told some features, then I mean, at the end of your history, if you had thought of all these, it would have been relevant that if you had mentioned some negative history suggestive of, I mean, history suggestive of these, especially musculoskeletal disorders, ankylosing spondylitis, rheumatoid SLE. Rheumatoid SLE, of course, agreed. This patient being a male, less likely, but you cannot exclude. And when you
Exposure to
mentioned
commercial sex workers. What is his occupation?
He's a supervisor in a construction company.
Okay. Which occupation is more likely to get exposure to commercial sex workers?
Drivers,
Can be anybody, but then
lorry drivers.
very good. Long distance drivers. Okay. And you have 3 regurgitant lesions here.
Yes,
Am I right?
yes, sir.
3 regurgitant lesions. So I think now we can move to what you want to offer as complete diagnosis. If the others also feel so?
Yes, please, sir.
Acute valvular heart disease, possibly rheumatic in etiology with mitral regurgitation, aortic regurgitation, and tricuspid regurgitation with features of pulmonary hypertension in sinus rhythm and heart failure with no signs of infective endocarditis.
So rheumatic heart disease with 3 regurgitations. How many cases you have seen like that? What is the commonest valve affected and what is the commonest lesion due to rheumatic heart disease? And what is the next common combination
The
in the
commonest,
order of occurrence?
commonest valve affected is mitral valve, almost 70 to 75% of the time. Mitral plus aortic is involved in 20 to
Mitral valve what?
so mitral stenosis.
Okay. Next combination.
So MS with MR.
Are you sure? MSAR. Okay. So little and there is no history of rheumatic suggestive of rheumatic fever in the childhood. Am I right? I
Yes.
missed a little bit of the discussion because of connectivity problem. Did you mention about that rheumatic fever history in the
No history of
past?
yes, but no history to just rheumatic fever.
So if there is no history suggestive of acute rheumatic fever, can you completely rule out rheumatic heart disease?
No, sir.
Why? What is a
So,
typical presentation of acute rheumatic fever in a child school going age usually?
fever,
Mhm. Acute rheumatic fever presentation.
fever, joint pain.
That's okay. I mean, be a little more specific. With joints, how will be the pain?
Migratory polyarthritis, fever.
Okay. Migratory means what? What is the meaning of migratory?
It will not be like additive of one joint. The pain will get better and then subsequently involves the other joint.
Randomly, right? Not in any sequential pattern. Okay. So come back to the case. You have 3 regurgitant lesions in a 50-year-old male. Anything else is coming to your mind as the etiology? If not, the next question is which one is the first one that would have occurred? Is it the MR or the PR or AR? Which would have started first?
MR.
Why?
There is pulmonary hypertension.
No, that is even if it comes later on, pulmonary hypertension can be there. To know which came first, you have to depend on your history. There's no other way, you know. So according to your history, symptom-wise, think about it. Which one would have came first? Still, rheumatic etiology is a little bit of stretching too much in this case, if you ask me. I don't know about the others. Please, sir. Sir. 3 regurgitant lesions. Others, please comment, sir.
Yes, sir, I agree, sir. I agree with you, sir. Possibility of rheumatic etiology, especially with the age group, the initiation of symptoms at the age of 55 as per your history, pretty long, pretty extreme of age for a rheumatic
Yes, sir.
etiology to present as such, and that too without a mitral stenosis, stenotic lesion.
Yes,
Looks to be, that not excluding entirely, but the differential would be much lower and you will have to consider many of the other differentials.
One question to the PG. If you think there is mitral stenosis, which is the commonest in rheumatic heart disease, also in this patient, and you are not hearing the murmur. That can happen. You're not hearing the murmur. What procedures, clinical procedures, you can try to bring out that mitral stenosis murmur in this patient?
Isometric exercise like hand grip increases mitral stenosis, MDM murmur.
Which one?
So hand grip.
Hand grip. How does it increase the intensity of mitral stenosis murmur? We are
Can-
talking about dynamic auscultation, right?
Yes, sir.
Yeah.
Systemic, when you during hand grip, systemic vascular resistance increases, and
then what happens? You want the mitral stenotic murmur to be clearer, or to appear rather. So which of the dynamic auscultation maneuvers may help? And not the hand grip. Hand grip is will increase the aortic flow resistance. Which are the other dynamic auscultation procedures, you know?
Valsalva maneuver, squatting.
Okay. Anything else? Have you heard of amyl nitrate? Amyl nitrate inhalation?
No.
It's okay. It's okay. And in this patient, you have an AR, you have an MR. So what happens to your assessment, clinical assessment of MS in the presence of these two lesions? You got my question, I think. If there is an MS,
Yes. Not sure.
which is not picked up clinically because, first of all, it's a mid-diameter. Even though it is the commonest valvular heart disease, it is the most difficult murmur to pick up along with AR. So MS murmur, what happens to the mitral stenosis murmur assessment in the presence of MR? First of all, we can say in the presence of MR only, then we'll talk about AR also. If there is MS, MR, which is going to be underestimated and which is going to be
Not sure, sir.
overestimated clinically. I think that we'll bring in the AR as well.
Not sure, sir.
See, my contention is that there may be an MS to save you your rheumatic etiology. There may be an MS because there are lots of events happening, lots of murmurs going on. So probably clinically it would have been a very soft, not soft actually, a very unclear murmur. So what happens to the MS murmur in the presence of MR? That's the question. In general. Will you underestimate the MS or overestimate the MS?
Sir is asking, in the presence of MR, is it possible that you might miss the findings of MS, which you will usually see?
Yes.
What findings do you expect in an MS? How will S1 be?
Yes, loud S1.
So in the presence of MR, will there still be a loud MS?
No, sir.
No. So there is a possibility that you may underestimate. Similarly, if there is a MDM in the presence of a very loud PSM, there is a possibility that you may even miss a MDM. Or on the other hand, if there is a mitral regurgitation, that by itself may cause a flow murmur.
What happens to MS and MR? Yeah. I'm sure you are understanding why the talk about MS is coming.
Yes, sir.
Because you still wanted to put in rheumatic heart disease as your etiology. So in that case, it's almost mandatory to have MS. to clinically say it is rheumatic etiology, but you are not hearing an MS murmur. So we are trying to get you to some possible reason why you are not hearing an MS murmur, even if it is present, the presence of other valvular heart disease. If there is MR, the backflow increases and the LA volume increases, and the MS is going to be overestimated. The flow through the mitral valve increases in the presence of MS. And then the mitral stenosis will be overestimated. Whereas in the case of AR, the LV volume is increasing because of the backflow, and then the mitral stenosis will be underestimated. I think you're following it. Are you hearing me?
Yes, sir.
Yeah. So I humbly suggest, please read about dynamic auscultation more clearly, and please also read the chapter in Braunwald or Dalen Alpert on combined valvular heart diseases. Combined valvular heart disease, one beautiful chapter is there. If there, they mention about what happens to AR in presence of AS, what happens to AS in presence of AR, all those, dynamics. Okay.
Investigations will order. I will
Shall we
order
proceed, sir?
Yes, please.
CBC, RFT, LFT, ECG, chest X-ray,
Yeah, please.
gram. Management wise, they should require valve replacement, diuretics, beta blockers, AC inhibitors or ARBs, and vaccination.
No, please, come to the postgraduate level. You want, the patient says, I have enough money, no problem. Do whatever you want, whatever surgery you want. I'm ready to go to the best center. What will you do in that case? Of course, you'll manage heart failure in the medicine ward or medicine department. But then what will you be doing? What is the ideal management in this particular patient? Ideal curative management.
Valve replacements.
Which valve will you replace first? In such patients, I request the cardiology professor to just elucidate. Sir, please.
I think Professor Vijay Samuel sir had to leave for an emergency, so sir is not online at the moment.
Okay. So the question is, uh, you're going to do valve replacement.
I think the question was not clear. So you said valve replacement, and sir was mentioning that if there were no resource constraints, what is the ideal surgical procedure that you would do, given that there are 3 regurgitant lesions in this particular case?
And which valve will you replace first? Valves or only 2 valves? Answer.
Mitral plus aortic valve replacement.
You will replace which valve first, or both together?
Mitral plus aortic valve.
Together. And what do you do with the TR? That also. No, I say You have to do one by one. Which one will you replace first? Or which one will you make normal first?
Mitral.
If you do a mitral valve replacement first, what is going to happen to the air? Will the air worsen or become better? Just think of the flow. You are replacing the mitral valve, the regurgitant mitral valve, and the flow through the mitral valve becomes more or normal, isn't it? The backflow is now prevented. So more blood will go to aortic valve, more aortic regurgitation will happen. So AR will worsen if you replace the mitral valve. I think you got the physiology. Simple. If you replace the aortic valve first, the backflow from the aorta decreases. So what will happen?
MR.
What will happen to the pulmonary hypertension?
Worsen, sir.
Hmm?
Worsen, sir.
Pulmonary hypertension will worsen or improve. MR will worsen or improve. It's okay. Okay, you please go through the hemodynamics once more. It's very difficult to discuss that on an online platform like this. But only one thing I can tell you is that such questions are expected when you present a case like this, especially when you talk about valve
Yes.
replacement.
Okay. What are the broadly, how will you classify prosthetic valves? And which valve will you prefer in his case?
The message probably I can tell over the mitral valve, normal size.
Would you prefer a bioprosthetic valve or a metallic valve? If you can just discuss what are the advantages and disadvantages of both. What is the advantage of metallic prosthesis? Which is likely to be more durable, more long lasting? Okay. Which one do you think will require lifelong anticoagulation? Okay. So that will tell you the advantage and disadvantage. Broadly, it will tell you what is the advantage and disadvantage of each of those. And what will help you to decide on which one to choose for the particular patient. Yes, good. So younger the age, you may probably go ahead, choose a metallic valve because you would want it to last longer. And similarly, bleeding risk. If someone has got a higher bleeding risk, you may probably want a shorter duration of anticoagulation and you will have to choose a bioprosthetic valve. Okay.
I request the postgraduate to just mention, I don't know if you don't know, so that on an online medium, otherwise it will be difficult if we go for a long silence, whether we just lost connection or you're not just talking. So if you don't know, please communicate. Thank you.
Okay. Okay. That any other questions from any of the other audience or expert panel members, please?
Which medication the patient has to be on after the transplant?
I think sir asked which medication will the patient have to be on after valve replacement. think at this stage you should be more specific on which anticoagulant you are going to choose. Why warfarin? Why not any of the other newer anticoagulant drugs?
Warfarin newer and also contraindicated metallic falls.
Yes, currently NOACs are prosthetic valves currently are not an indication for starting NOACs. So the only oral option that you have is warfarin or vitamin K antagonist, as you said. Yes. Any other questions from the panelists, sir? Okay. Yes, that there are no further questions. If there are no further questions, then I would like to congratulate the speaker, Dr. Lino, for having taken the time to work up a patient in detail and present in this forum. A round of applause for Dr. Lino, please. And also thank you so much, sir, for your valuable questions and comments. They are up to the standard and expected questions at a postgraduate level in any postgraduate examination. Thank you so much, sir, for your insights as well. And also my sincere thanks to Professor Vijay Samuel, sir, also. Unfortunately, sir had to leave a little bit early due to some emergency. And thanking sir also for his valuable insights towards the beginning of this session. And thank you for all attendees for having attended this session. And with that, we come to the end of today's session, and we'll meet next week. Thank you so much.
Are we finished?
Hello. Hello.